بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, now we will handle one of the tough topics in the musculoskeletal imaging, which is the diagnosis of soft tissue tumors. And in my opinion, this was the remaining part that I did not handle before, and I will handle this topic in 3 or 4 parts. And starting by the first part, this is a long topic, of course, as you all know, but we will try to simplify it as much as we can. To start with is how to image the soft tissues. We have the plain X-ray, ultrasound, CT, and sometimes bone scan or PET scan, MRI, angiography, especially the CT and MRI. Then we many times will need the biopsy. Most of the soft tissue tumors arise from one of these components of the limb. For example, the skin and connective tissue, the fat, the muscles, blood vessels, the lymphatics, the peripheral nerves, and the synovial lesions. Of course, you have many of the soft tissue tumors that we are not able to identify the exact cell of origin, and also we'll handle many of the other tumors like lymphoma and metastases to the soft tissues as well. As a general rule, we have the initial evaluation is carried usually by X-rays and ultrasound, although many of you will feel that X-rays will be of limited value, but actually X-rays have an important role in the evaluation. Then by X-ray and ultrasound, if we succeeded to decide that this is a benign lesion, then no further evaluation, I think, is needed. But if this lesion is not benign, it looks malignant, looks of intermediate characters, then we have to proceed by MRI. Then finally, we should have a biopsy either guided by ultrasound, CT, or even by MRI. And these are the rules of or the values of the X-rays. They may show some soft tissue tumefaction. They may show radiolucency denoting fat density of the lesion, some radiodensities denoting the presence of calcium, which is an important factor for the differential diagnosis. Also, the detection of air may indicate the presence of superadded infection. Then the changes in the adjacent bone, like the periosteal reaction and sometimes cortical erosion. And this is an example of a malignant tumor known as myxofibrosarcoma in the medial aspect of the thigh. The only thing here is to see that there is some soft tissue swelling, extra density, obliteration of the usually seen intermuscular fat planes. But here you see an X-ray of the elbow, and you can see the radiolucency of the tumor, which is corresponding to its fatty nature, and this was a lipoma. Then here you see a clear cell sarcoma arising in the upper arm, and the presence of here, as I have mentioned before, indicate the superadenine infection in this tumor. Then we came to the ultrasound, which is considered one of the major diagnostic imaging modalities for evaluation of soft tissues. Ultrasound is readily available, it is non-invasive and relatively an inexpensive technique. It is used, as I have mentioned, for early evaluation of the soft tissue tumors to separate benign from non-benign masses, and also it can show the size, the location, the consistency of the lesion, and it can easily differentiate between cystic and solid lesions. Also, ultrasound is sensitive in detection of the deep margin of the lesion, especially if you have the ultra high frequency. Also, it is an effective method in detection of early local tumor recurrence. And of course, by the help of Doppler ultrasound, we can have a good idea about the tumor vascularity, and we can also assess the response of the tumor to the therapy administered. And this is the broad general rules about the ultrasound criteria of a benign lesion. These include that the lesion is small in size, of homogeneous texture, well-defined margin, superficially located, and is seen displacing the surrounding structures rather than invading them. Then the ultrasound criteria suggestive of a malignant lesion include the big size, irregular margin, heterogeneity, and architectural disorder, and also, of course, invasion of the surrounding structures. And this is a description for the facial tumor relationship as detected by ultrasound and its value in differentiating in most of the cases between benign and malignant lesions. Then the tumors without facial contact, like this one, group 1, are considered benign. Also, tumors with minimal facial contact are also benign, but tumors with somewhat broad facial contact and acute angle, and this are intermediate group between benign and malignant, then tumors with obtuse margin and also tumors invading the underlying fascia, and these are considered malignant. In ultrasound also can be used to guide biopsy taking and also to aspirate collections, and many times it can be used to also perfuse some of the chemotherapeutic drugs. Ultrasound and especially the Doppler can monitor the tumor vascularity and its response to systemic chemotherapy. It can also use to detect local tumor recurrence in patients with metallic fixations that cannot who cannot be examined by CT and MRI because of the artifacts. The ultrasound in the 3D display can help in the interventional techniques. It can guide the needles or the catheters to avoid the necrotic areas and also to avoid the major vessels in the track of the needle. Then changes in the tumor blood flow is also used to monitor the effect of chemotherapy, meaning that the tumor that was hypervascular and on the follow-up study became relatively hypovascular. This means that it is responding. Then this is one of the best examples that ultrasound can confidently diagnose the benign lesion. And these are the criteria. The benign is a homogeneous lesion which is usually cystic with a strong acoustic enhancement and sharp margin with no abnormal vascularity on Doppler study. This is a confident diagnosis by ultrasound that this lesion is a benign one. Then CT is not considered by many as a part of the protocol in examination of the soft tissue tumors, but CT is very important in diagnosis of periosteal reaction, and it can also see erosions better than X-ray in the cortical bone adjacent to the tumor, also calcifications that are subtle which are not detected by plain X-ray nor ultrasound, can be better seen by CT scan. The detection of minimal gas within the soft tissues is not feasible by MRI and also by plain X-ray. Then this is an obstacle that post-operative metallic hardware can produce artifacts that distort the scanning field. Uh, Also, we can use the angiographic technique to see the tumor vascularity. CT is considered the only one of the three imaging modalities to see lung metastasis. But of course, you can see lung metastasis by plain X-ray. But if the mets are very small or minute, CT is able to discover them. Then is also a guide for many of the interventional techniques if ultrasound is not available or cannot be performed. And this is an example of a soft tissue hemangioma in the vicinity of the knee joint, showing the classic calcified foci diagnostic of Filippuli. And this is one of the easy diagnoses which can be achieved from the plain X-ray. Then the role of PET-CT in evaluation of soft tissue tumors is only confined to the search for metastatic disease and also to look for recurrence after treatment. Then PET-CT is not a diagnostic modality. PET-CT cannot replace CT or MRI in the diagnosis of soft tissue tumors. PET-CT is only, in my opinion and in the opinion of many, is reserved to assess the post-treatment tumor recurrence and also to look for metastatic disease. And this is the one of the examples of a malignant soft tissue tumor and the response of therapy after treatment. MRI is one of the major tools in evaluation of the soft tissue tumors, and it should precede biopsy taken. MRI, of course, will have the three-dimensional imaging, and they can use the fat suppressed techniques to detect the fat content of the lesion and to much more delineate the lesion after, especially after contrast injection. Then fat suppression is also recommended when the tumor abuts or infiltrates the adjacent fat. We do not use fat suppressed T1 or T2 without their non-fat suppressed equivalent, because the comparison between the fat suppressed and non-fat suppressed images is very helpful to reach the diagnosis. Then MRI is very good for accurate anatomic localization of the lesion and also to delineate the relation of the tumor to the neurovascular bundle and evaluate accurately the relation of the tumor to the adjacent bone. And MRI is very important in preoperative anatomic staging of the tumor. Then the criteria of a benign lesion based on MRI findings include small size, homogeneous density, homogeneous signal intensity, and smooth margin with no invasion of the adjacent structures. The literature indicates that only 5% of benign lesions can grow more than 5 centimeters. The signal intensities can help if you can detect fat, you can detect the fluid, you can detect the blood or melanin inside the tumor. But as a general rule, the MRI signal characteristics are not specific in the majority of soft tissue tumors, as I will mention at the end of these talks. Then We have two methods for injection of contrast material by MRI: the static contrast enhanced images with fat suppression, and the dynamic contrast enhanced MRI, which are valuable in number one, distinguishing benign from malignant tumors according to the previously mentioned criteria, monitoring the response to chemotherapy, and may guide the biopsy procedure, and also can help in early detection of the tumor recurrence. Then these are some of the important notes about MRI: that early, rapid, progressive peripheral enhancement may favor the diagnosis of malignancy. Dynamic MRI is considered the method of choice to monitor preoperative therapy. And dynamic MRI can help in differentiation between the tumor from the surrounding edema. Diffusion MRI is not helpful in differentiation between benign and malignant. However, MR spectroscopy may help sometimes in differentiation. Gradient images are sensitive for the blood elements and the calcium. They are may be routinely obtained if there is a suspicious of these two components in the tumor. Also, one of the important issues that if you are interested in evaluation of the relation between the tumor and the neurovascular bundle, this is obtained in the axial images. As I have mentioned, MR spectroscopy may sometimes help to discriminate between benign and malignant tumors. Then biopsy is one of the essential tools for the battery of investigation of soft tissue tumors. And ultrasound can be used as a guidance to guide the needle for superficial lesions, and we should select the shortest path between the skin and the lesion, and the needle should not transverse an uninvolved compartment if possible. The entry port and the pathway should avoid nerves, major vessels, and sometimes, if you can, the visceral structures. Then we came to the core of these lectures: the soft tissue tumors. Soft tissue tumors in the evaluation need the collaboration between the radiologist, the pathologist, and the clinician. And, clinical information is very important. It can help many times, as you will see, in reaching diagnosis even without the need for imaging. Initial evaluation, as I have mentioned, should be obtained by the plain X-ray and ultrasound, or both. If the lesion is not definitely benign, then you go for MRI, which will be followed in most of the cases by biopsy taking. Then MRI, as I have mentioned, is the best way to detect local tumor recurrence, and also you can use sometimes the PET scan. The close cooperation is essential between the involved personnel. Then the classification of the soft tissue tumors will depend on the cell of origin. And we have 12 major categories of soft tissue tumors. The tumors arising from the skin and the connective tissue, tumors arising from fibrohistiocytic cells, then tumors of fat, tumors of the blood vessels, tumors of the lymphatics, tumors of the muscle, synovial tumors, tumors of the nerves, and extraskeletal cartilaginous and bone tumors like chondroma in the soft tissue, even sarcoma in the soft tissue, and so on. Lesions of uncertain origin, I have mentioned that many times you can not identify the cell of origin of the tumor. Then we'll have a short talk about metastasis and the lymphoma of the soft tissues. Then I will give you some examples of lesions that may be mistaken as a soft tissue tumor, but they are not. Then we'll start by the first group of lesions, which include 11 examples. and these are the fibroblastic tumors. They will include the nodular fasciitis, nuchal fibroma, elastofibroma, fibromatosis, plantar, and Bulmer, as well as abdominal desmoid tumor, extra-abdominal desmoid tumor. Then we'll discuss the solitary fibrous tumor and hemangiopericytoma. And the malignant parts are the infantile fibrosarcoma and the adult fibrosarcoma. Starting first by the nodular fasciitis, and this is a rapidly growing non-neoplastic soft tissue lesion, which is frequently seen in the deep subcutaneous region or in the fascia, and it may be mistaken for sarcoma because of its rapid growth. The common sites or locations include the forearm, lower limb, the chest, and the back, and the age incidence is between 20 and 40 years, and the symptoms include tenderness, pain, and sometimes these lesions are considered as reactive to a previous history of tumor, and some literature suggests that this is a neoplasm. The lesions are usually small in the range of 4 centimeter or less. Then the nodular fasciitis will appear as a well-defined isoechoic or hypoechoic lesion, and they will show some vascularity on Doppler ultrasound. Because of the fibrous content, they will appear hypointense signal in all pulse sequences in T1 and T2, but some of these tumors are hypercellular. They will show hyperintensity on the T2 weighted image, and they will show, of course, contrast enhancement. And this is an example of a lesion in the groin. By ultrasound, it looks hypoechoic with some vascularity. This patient is a practitioner, a general practitioner, who is cancer phobic and presented by a palpable mobile solid nodule in the upper right thigh. The MRI T1 weighted image showed the lesion, and after contrast injection with fat suppression, you can see considerable enhancement. The differential diagnosis of nodular fasciitis include bulbar fibromatosis, desmoid tumor, neurofibroma, fibrous histiocytoma, and soft tissue sarcoma. I will mention in details how can you separate these from each other. And this is another case of nodular fasciitis in the upper arm, and by you can see here in the coronal T1, low signal intensity, and the high signal intensity in the T2 and the stir images. What looks like a cyst, but the ultrasound in this particular case excluded the presence of a cystic lesion or an abscess. It showed the homogeneous solid lesion, and this was proved to be nodular fasciitis. Nuchal fibroma is a benign tumor seen in the back of the cervical spine or in the subcutaneous tissues, commonly seen in the interscapular region or paraspinal area, and they are common in men. They present between the third and fifth decade. They are of low signal in the T1 and high signal in the T2 weighted image, and can show contrast enhancement. As you can see here, and this is a low signal lesion in the T1 with increased signal in the T2 and a strong post-contrast enhancement. The bright signals within the lesion represent entrapped fat within the collagenous soft tissues of the tumor. Then the third one, which is a famous one known as elastofibroma dorsi, and this is a benign lesion with characteristic site and a very characteristic imaging appearance. Is commonly seen in older women, and this is the male to female ratio 13 to 1, 13 for females and 1 to males. The age of incidence is around 70 years, and it is seen in the infrascapular lesion deep to the serratus anterior and latissimus dorsi muscle. This lesion will show this very characteristic appearance of striated mass containing bright signal in the T1 representing fat and intermediate signal representing muscle fibers. Then most of the patients are asymptomatic, but many times they may feel a swelling and may also complain of pain. This is the CT appearance. The tumor may be unilateral, maybe bilateral, maybe symmetric, maybe asymmetric. And this is very characteristic appearance both on CT images and on MRI. If you have the PET CT and then the lesion may show some uptake. And the T1 weighted image, there is a striated appearance with a characteristic location, and the T2 weighted image, you see also similar findings. And this is a CT scan of a bilateral, almost symmetrical elastofibroma dorsi. And here you see the classic appearance of a lesion in the T1 in the STER image, and after contrast injection, the tumor can show some contrast enhancement, but its site and its characteristic location is very helpful in the differential diagnosis. Then we came to the fibromatosis, and these are fibroblastic proliferation of benign nature. We have superficial fibromatosis, palmar, plantar, and benign fibromatosis. Deep fibromatosis include the extra-abdominal, the abdominal wall, and intra-abdominal fibromatosis, which can occur in the pelvis or in the mesentery or in association with Gardner syndrome. Palmar fibromatosis is also known as Dupuytren contraction. This is a fibrosing condition characterized by firm nodularity on the palmar surface of the hand. It very commonly seen in the fourth ray, typically the fourth finger or the fourth metacarpal, and also maybe the fifth as well. Bilateral lesion is seen in about 50% of the cases, and this is the incidence, 1 to 2% of the population, especially seen in Northern Europe, and the age of presentation is about 65 years old. This lesion is diagnosed by clinical appearance and usually needs no further evaluation by ultrasound or MRI. But if you have ultrasound, this lesion will appear hypoechoic to the tendon with some hypervascularity, similar to the previously mentioned. And the chronic nodules can appear hyperechoic without vascularity. MRI will show low signal in the T1 and T2 weighted images. The treatment of a choice is excision. The recurrence rate is very high, and recurrent lesions are usually more aggressive. And this is palmar fibromatosis by ultrasound Doppler. And you see the vascularity and you see the hypoechoic nature of the lesion. The second is the plantar fibromatosis, which is present in the plantar fascia, and it appears as nodules and masses located medial to the middle, sorry, me, in the middle to the medial aspect of the plantar arch. And this lesion do not cause flexion deformities in the foot. It will appear hypo to mixed echogenicity. By MRI, it will show low signal in the T1 and T2 and show variable enhancement. And this is the plantar fibromatosis showing the hypoechogenicity of the lesion. And by MRI, they see the lesion is more or less well defined with low signal and is located in the plantar aspect of the foot. And this is another example. And you see the lesion is located in the subcutaneous fat superficial to the plantar fascia, and it shows low signal intensity. Then desmoid tumor is also a benign lesion, which is characteristically seen in the anterior abdominal wall, and the exact etiology of this tumor is not fully understood, and this lesion is considered rare, frequently seen at this age group between 20 and 40 years of age, more common in women, frequently located in the anterior abdominal wall, can be seen in the mesentery and retroperitoneum. And this is a good example of a desmoid tumor in the anterior abdominal wall corresponding to the site of the rectus abdominis muscle. It shows mixed hypo or heterogeneous echogenicity by ultrasound, and in the CT it will show homogeneous soft tissue mass that will show contrast enhancement. MRI will show signal intensity hypo-intense in the T1 and T2 with a variable amount of contrast enhancement. These are two different cases of desmoid tumor in the anterior abdominal wall. There's the T1 appearance of intermediate signal, some bright signal in the T2 weighted image. In the other case, you can see the pre-contrast and post-contrast with some enhancement of the lesion. Intra-abdominal desmoid is a very rare lesion, and in most of the cases, it is asymptomatic, and lesions can can grow slowly and can invade the adjacent structures. They may cause sometimes intestinal obstruction or organ ischemia or even urinary tract infection. This lesion is usually mistaken for inflammatory intraperitoneal lesions, for liposarcoma, fibrosarcoma, and even for guest tumors. Surgery, of course, is the line of choice for treatment of asymptomatic patients. Then, as for most of these fibromatosis, the recurrence rate is considered high. And this is in a photograph of the abdomen of a male patient, 33 years old, with a CT scan showing a very big mass in the peritoneum with heterogeneous contrast enhancement as well as areas of breakdown inside the lesion. And this is also another example of a pathologically proved mesenteric desmoid tumor. It cannot be differentiated from other tumors in the mesentery, like lymphoma, for example, or leiomyosarcoma, and most of the lesions, and we usually reach the diagnosis by biopsy. Another example of a desmoid tumor. Uh, of course, you cannot diagnose this as a benign lesion from its margin because many of the malignant lesions may have this margin, and the diagnosis, as I have said, should be reached by biopsy. And this is another example in a female patient, 40 years old, with a big solid mass in the peritoneal cavity, diagnosed as mesenteric desmoid. And this is a mesenteric desmoid tumor, which is intimately related to the anterior abdominal wall, showing heterogeneous post-contrast enhancement. And you know that patients with familial bullosis on this tumor is part of the Gardner syndrome, as you all know. And this is also another example of a mesenteric desmoid tumor intimately related to the inner aspect of the anterior abdominal wall. And extra-abdominal desmoids are known as aggressive fibromatosis. They are slowly growing benign tumors with a very high incidence rate of recurrence. And the patient may present by painless swelling. The deep lesions may cause contractures or pain or organ dysfunction. Gardner syndrome is associated with increased incidence of extra-abdominal desmoids. The X-rays may show some calcification or cortical erosions. The CT is of limited value. MRI is also of limited value. It will show a homogeneously iso-intense signal in the T1, high signal in the T2, and a significant contrast enhancement, which is, of course, are non-specific findings seen by many of the soft tissue tumors. So the T1, you see the lesion in the T2 and significant post-contrast enhancement. And this lesion is followed up over 2 years and 6 years, and you can see the big lesion in the back of the lower thigh with heterogeneous post-contrast enhancement. The follow-up after 2 years showed regression or decrease in the amount of the enhancing tissues with mature, let us say, mature fibrous tissue, which is replacing most of the tumor bulk. And the follow-up after 6 years showed that the tumor is also almost of the same size with regression, marked regression in the enhancing component. And this is also a desmoid tumor with uncharacteristic MRI finding, T1 weighted image, low signal, T2 weighted image, high signal, and significant enhancement. Then we came to what's known as the solitary fibrous tumor. And this is a benign lesion representing about 2% of all soft tissue tumors. And you may remember this name that is mentioned frequently whenever discussing the brain tumors. And this is, of course, the new name of the meningioma. Then this soft tissue tumor is in order to remember its characters and imaging appearance, remember the characters of a meningioma. This is a slowly enlarging painless mass, and the tumor is located in the soft tissues. It can be seen in the pleura, it can be seen in the face, and also, of course, in the meninges. This lesion may show homogeneous signal intensity and density with homogeneous, usually, or heterogeneous post-contrast enhancement. It can contain calcium in about 10% of the lesions. The MRI in the soft tissues of the soft tissue solitary fibrous tumor, the MR appearance is non-specific with intermediate signal in all pulse sequences, almost similar to that of the meningioma. Malignant soft tissue solitary fibrous tumor is previously known as the hemangiopericytoma, but there is some change in the names of the tumors, as I will mention in a moment. Then, malignant soft tissue tumors have an infiltrative margin, and they may produce metastatic disease in about 10 to 15% of the cases. Surgery is recommended for treatment of both benign and malignant tumors, and long-term follow-up is mandatory because of the local tumor recurrence and the distant metastasis. And this is a soft tissue mass of low signal intensity at the root of the neck of this child, 2 years old. And this was suspected from the clinical point of view and ultrasound to represent a neurofibroma. But by biopsy, this was proved to be a solitary fibrous tumor. Another lesion, which is seen in the medial aspect of the upper thigh of this female, 19 years old, showing significant heterogeneous contrast enhancement and was proved to be a solitary fibrous tumor. And another case of a solitary fibrous tumor in the upper leg. The lesion showed low signal in the T1 and it shows significant contrast enhancement in this T1 fat suppressed image. This arrow points to a vessel which is directed to the tumor, and this is one of the helpful diagnostic signs because these lesions are usually hypervascular. Then here you see a solitary fibrous tumor in the lower part of the thigh, and after contrast injection, you see the heterogeneous contrast enhancement. Also, a solitary fibrous tumor in the perineum. This is T1 and this is T2 and this is T1 post-contrast fat suppressed images showing this appearance. And you know that the fat suppressed areas within the tumor represent usually fat elements, and this was proved to be lipomatous hemangiopericytoma. And this is also an example of lipomatous hemangiopericytoma. In I will mention in a moment the relation between solitary fibrous tumor and the hemangiopericytoma. Then you see the tumor, and you see a fat component in the T1 and in the T2 weighted image after contrast injection. You can see heterogeneous post-contrast enhancement, and this is the appearance of the fat within the tumor by CT image. Then here you can read the solitary fibrous tumor and hemangiopericytoma are histologically similar and currently used almost interchangeably and are thought of as a benign part of the same histopathologic spectrum. Then when you also remember this for the brain. And now the classification of brain tumors include solitary fibrous tumor and hemangiopericytoma as a single entity, and they differentiate according to the imaging modalities if the tumor is uh, low grade or high grade and so on. Then this is hemangiopericytoma, and by ultrasound you see extensive hypervascularity, and also by MRI you see the extensive hypervascularity. Now we came to the malignant component of the previously mentioned group of the tumors, and we have the infantile fibrosarcoma and the adult type of the fibrosarcoma. Infantile infantile fibrosarcoma is similar by histology to the adult fibrosarcoma, but the tumor biology here is quite different because this is a little bit not that aggressive. It represents 12% of the soft tissue malignancies. Most of the cases are detected in children younger than 2 years, and 50% of cases are diagnosed at birth or even antenatal. The tumor is slightly more common in boys and frequently arises from the extremities, the trunk, and the head and neck. It's a rapidly growing mass with dense erythematous appearance and may be associated with ulcerated skin, and sometimes it can be clinically mimic a vascular malformation. This tumor is the hypervascular lesion. And the hypervascularity is seen on ultrasound Doppler and also by MRI. You can see multiple dilated tortuous signal void vessels within the tumor and along the periphery of the tumor. Ultrasound will show the heterogeneous hypervascular mass, which is sometimes similar to a hemangioma. An MRI shows a large heterogeneous mass with well-defined infiltrative margin. Multiple signal void vessels, hemorrhage, and necrosis are common. Metastatic disease is seen in 8% of the cases, most commonly to the lung, and the tumor is associated with an excellent disease-free survival rate. This is the major difference between the infantile fibrosarcoma and the adult type. This is an infantile fibrosarcoma. You see a male infant, 4 months old, with a big mass in the leg, low signal in the T1, high signal in the stair, and the heterogeneous post-contrast enhancement. And this is a lesion in the arm of an infant, 3 months old, and the mass showed some high signal in the T1 indicating the presence of hemorrhage. And this is also high signal in the T2 with the image with heterogeneous post-contrast enhancement. Then the malignant one is of adults is known as the adult type of fibrosarcoma. But this name has been changed in the recent classification of soft tissue tumors by WHO, presented in 2012. Then both adult fibrosarcoma and malignant fibrous histiocytoma are included under this name, pleomorphic undifferentiated sarcoma. This is considered the most common type of soft tissue sarcomas, and it reaches about 40% of these tumors. It has an aggressive biological behavior with poor prognosis. The age of presentation is around 60 years, and the presentation by painless enlarging soft tissue mass can occur anywhere with predilection for the extremities. The imaging findings are non-specific and calcifications may be seen in about 20% of the cases. This is, let us say, pleomorphic undifferentiated sarcoma, or you may say adult type fibrosarcoma or malignant fibrous histiocytoma. And you see in the T1 and T2 weighted images, a big soft tissue mass involving the subcutaneous fat, and you cannot see a specific criteria for this lesion unless you may be able to say that this is malignant because of the invasion of the surrounding and the poor definition of the margin, for example. Another example of pleomorphic undifferentiated sarcoma, low signal in the T1, high signal in the T2, and almost homogeneous contrast enhancement with invasion of the adjacent muscles. Another example, and this is T2, this is STER, and this is T1, post contrast with fat suppression. And you see a lesion which is located inside the muscle group of the mid of the lateral aspect of the thigh, and you cannot have enough diagnostic criteria to say that this is a malignant one. But here is a lesion in the groin, and you can see a heterogeneity in the T1 and T2 with some blood elements within the tumor, and also you see the heterogeneous post-contrast enhancement. And here is stated that the intermediate signal in T1 and the bright signal in T2 is due to myxoid degeneration within the tumor. And finally, these are some of the important points that you should remember that tumors of the connective tissue are common. The benign tumors usually have characteristic location like elastofibroma in the chest wall, palmar and the plantar fibromatosis, nuchal fibroma, and abdominal desmoid corresponding to the rectus abdominis muscle. Desmoid tumors are aggressive with high rate of recurrence. Fibromatosis coli is seen within the sternomastoid muscle in the newborn. Hemangiopericytoma moves from the vascular to the connective tissue. Thank you very much. Alhamdulillah Rabbil Alameen.